And that should do it. So without further ado, I would like to kick off our session. We have Graham Prentice-Mott from the CDC. Graham, if you'd like to unmute and share your slides.
Thanks, Darcy. Are you able to hear me? Great. Well, so I'll get started. Happy to be here with everybody today. Can you all see my slides?
Not
no,
yet.
we cannot.
Okay, hold on one second. How about now?
Yes, now you're good.
Great, thanks. Hello, my name is Graham Prentice-Mott. I work in the Waterborne Disease Prevention Branch at the US CDC. I'm here to talk about an evaluation of a sanitation technology known as Sadopan, which was evaluated in healthcare facilities in Western Kenya. I want to first acknowledge the collaborative effort and all the contributions from colleagues both within CDC and the Safe Water and AIDS Project. To start, I want to talk a little bit about sanitation in healthcare settings. Rural facilities in low and middle income countries face substantial challenges meeting wash needs. A recent study of several countries in sub-Saharan Africa estimated that in Kenya, only 30% of rural facilities fell into the improved category for each of water, sanitation, and hygiene. And when most rural Kenyan facilities had improved sanitation, there was a substantial number, 39%, that reported issues with cleanliness, latrine conditions, and privacy. Upgrading sanitation presents particular challenges: lack of sewage, high construction costs, water scarcity, the need for ongoing repairs. All these make flush toilets impractical in many healthcare settings. Indeed, in rural Kenyan health facilities, pit latrines are the most common type of sanitation. Given this, there could be a role for intermediate sanitation upgrades. If able to improve user experiences, the ability to implement upgrades today could present a useful strategy while awaiting needed long-term infrastructure development. What is a Sadopan? Sadopans are fiberglass inserts designed to be mounted on existing latrine slabs with keyhole openings. They are relatively inexpensive. In Kenya, they are locally produced in Nairobi and cost around $15. Installation does not require special tools and can be completed easily with little training. The main feature of a Sadopan is the trapdoor, which operates with a weighted hinge. The trapdoor is designed to open with the weight of 200 milliliters of water, allowing waste to fall into the latrines. Afterwards, the trapdoor swings closed again, so in effect, the Sadopan acts as a seal for the latrine hole. For this evaluation, instructional materials were posted in the latrine compartment during installation. This type of latrine cover could serve to block flies, a known vector of infectious disease, limit odor, and improve the latrine user experience. Sadopans have been assessed for acceptability in household settings in countries such as Zambia, where it was found they were a highly preferred alternative sanitation option. However, to our knowledge, Sadopans have not been evaluated for the potential to improve user experiences, especially in public or shared latrines. From the spring of 2019 until the fall of this year, in partnership with the NGO Safe Water and AIDS Project, also known as SWAP, the CDC conducted an evaluation of Sadopans in rural health facilities in Western Kenya. Within these two Kenyan sub-counties, all health facilities were selected to participate in the evaluation for a total of 37 facilities, with roughly the same number in each sub-county. Intervention and control facilities were randomly selected and mixed throughout. The trial began with a baseline assessment in all health facilities. We adapted the standard primary healthcare facility assessment survey developed by CDC's Global WASH team. This tool is available from the URL provided here. Next, pit latrines in the intervention facilities were equipped with Sadopans. This allowed an assessment comparing Sadopan latrines to standard pit latrines. The results I'm presenting today are from this assessment. Afterwards, Sadopans were installed in the health facilities in the control arm. This was only done after first checking if the health facility administrations were satisfied with and still wanted Sadopans. With the intervention implemented in all facilities, this allowed a follow-up monitoring assessment to have a chance to make some iterative improvements to the intervention and assess the effectiveness. As mentioned before, assessments were conducted to establish conditions in the health facilities. Cleaners were also interviewed. I'll briefly mention in-depth interviews were also conducted, focusing on perceptions, challenges, and implementation experiences. However, the results I'm presenting today were primarily obtained from methods I want to mention next. Throughout the evaluation, intercept interviews were conducted with latrine users. These were patients, visitors, and healthcare providers. The interviews focused on user experiences and preferences related to latrines in the health facilities. Lastly, observations were carried out of the latrines themselves by trained enumerators. In addition to observing latrine conditions, we wanted to estimate the prevalence of latrine flies. One of our primary aims was to assess whether cytopans can reduce flies, improve cleanliness, and limit odor, given the importance of these features in the user experience and the potential to disrupt an important disease transmission route. To obtain estimates for latrine flies, equal length strips of fly tape were hung inside the compartment of all pit latrines, those with cytopans, as well as standard pit latrines. Next, the evaluation team returned to the health facility after a 24-hour period, and the number of captured latrine flies were counted. Counts from both baseline and end line were conducted by the same individual who had been trained in the identification of this fly species. For end line analyses, a total of 61 cytopan latrines were compared to 71 standard pit latrines. Given there were some intervention facilities that requested not to have all pit latrines equipped with cytopans, the comparison group of standard pit latrines included 10 latrines that were actually in intervention facilities. Before going into statistical methods, I want to emphasize this analysis is a work in progress and these models are preliminary. When modeling outcomes, we use generalized estimating equations to account for the correlation between latrines within the same block and health facility. And we modeled these 4 end-line outcomes separately. The presence of any captured latrine flies, strong or unbearable odor, any visible feces on the latrine floor or drop hole, and any standing urine or water inside the latrine compartment. Each model also controlled for the baseline characteristic of the outcome aggregated at the health facility level. Fly and odor models controlled for whether the latrine was a ventilated, improved pit latrine. The urine model controlled for whether latrines are cleaned at least daily at the health facility. Here, I'd like to share our preliminary findings. We found cytopans were associated with decreased odds of having latrine flies. We also found cytopans were associated with decreased odds of enumerator-reported strong odor. On the other hand, there was no association between cytopans and visible feces, nor with urine or water. This finding suggests cleanliness, as defined here, may really depend on the cleaning schedule within the health facility and not necessarily the toilet design. There are some limitations that should be noted. Odor was self-reported by enumerators who were not blinded to the intervention. Although odor was reported before fly tapes were hung, so qualifications of odor were made independently of fly presence. Additionally, given that not all pit latrines and intervention facilities had cytopans installed, the presence of flies could have been affected by standard pit latrines within the same block. However, we do see a strong association with decreased odds of flies, suggesting any latrine neighbor effect may be minimal. This finding is further supported by responses within latrine user interviews. At endline, patients, visitors, and staff, those who reported using a toilet or a latrine at the health facility within the past week were asked whether they had observed any flies, any odor, or any visible feces. Comparing user experiences of cytopan latrines to user experiences with other types of latrines or toilets, users seem to have observed visible feces at fairly equal rates. This tracks what we found with observations of the latrines themselves, where there was no difference for visible feces. However, we can see that users reported having observed flies and odor notably more frequently when using standard pit latrines or toilets. Latrine users were independently reporting the same differences as those we'd seen from our fly counts and enumerator observations. Similarly, 18% of respondents in the control arm indicated that the latrines in the health facility were not acceptable for use, compared to only 4% in the intervention arm. It is important to take into account these responses as well, because this includes the perceptions of respondents who may have declined to use latrines due to poor conditions. When taken together, interview responses combined with model results to strengthen the case for these differences. In conclusion, to our knowledge, this was the first observational assessment of this specific intermediate sanitation upgrade, the cytopan. and its potential to improve latrine user experiences in a healthcare setting. Our preliminary findings show evidence Sato pans may be associated with a reduction in the presence of latrine flies and strong odor when equipped in a health facility. This type of upgrade to existing sanitation infrastructure could represent an improvement and lead to acceptability for more latrine users. I'd just like to say this analysis is ongoing, including analysis of qualitative interviews. We hope to explore challenges related to Sato pans in this setting, as well as develop recommendations for how to implement them. Sato pans need water for flushing, which can present challenges for health facilities with water access issues. Additionally, there's a short time window to train latrine users visiting public facilities who are unfamiliar with Sato pans. New users, if insufficiently trained, may decline or have difficulty using Sato pan latrines. We hope to address these questions as we move forward. Thanks for your time and attention. I hope everyone can access the chat box, and if you have any questions, please feel free to type them there.
Great. Thanks for that presentation, Graham. Again, please enter your questions into the chat box, and I will be going through to set up those questions for Graham. So we have one here that asks, did the Sato pan installation require replacing the entire latrine slab, or was it fitted onto existing latrine slabs?
It was fitted onto existing latrine slabs. We used an artisan. It took just a little bit of training for the artisan to be able to know how to fit the Sato pans on existing slabs. One thing is if you have something like tile, which can be common in healthcare facilities, it sometimes requires like a little bit of artistry to kind of cut around the tiles and fit it to the latrine slab. But it has to have a keyhole opening, a typical pit latrine that we see.
And then there's a follow-up there about costs and what this might look like in relation to other options that a health facility might use.
I think in terms of cost, we have to think of it not. So other options that a facility might use would be, I guess, rehabilitating a full latrine or equipping a latrine with a ventilated improved pit latrine configuration, and which is obviously much more expensive, or the cost of installing flush toilets and equipping flush toilets to a sewerage system or equipping them to piped water. Those are the kind of costs that we compare this to, and given that those can be impractical in many cases, something like this fiberglass insert might just be a really nice, inexpensive way to just improve the latrine a little bit while you're awaiting those larger improvements to latrine infrastructures.
Great. Let's see. There's someone who's asking, what are your thoughts on why some healthcare facilities did not want the Sato pans?
Sure. We actually asked that question. If I can get back to my slides. We asked that question to the in-charges. Those are the health facility administration, to the cleaners, to the healthcare providers, the staff. And most of them were really satisfied with the Sato pan for these reasons. They felt it was easy to clean, it stayed clean, it didn't smell bad, and didn't have flies, or what we went over before. But in terms of why they would want to maintain pit latrines without Sato pans, there was reports of urine backsplash, given the configuration. And some patients, if you're not able to train the patients and they don't know exactly how to use the Sato pan, they might not use it properly. And also flushing water can be a problem for some health facilities.
Yeah, I think. Yeah, so to follow up on that issue of flushing water, can you speak to the amount of water and labor that's needed to refill and to maintain these pans?
Sure. We interviewed cleaners, and 81% said they refilled the buckets at least daily. So the other 19% didn't even refill buckets daily. So those must have been, we had a mix of regional hospitals and small dispensaries, and so the patient volume, I'm sure, really is a determining factor for that. But they said that they usually spend around 30 minutes or so getting water for these flushing buckets, which doesn't seem a lot, but one thing we were hearing in qualitative interviews initially was that this was an added burden for cleaners, and they viewed it as something that made their jobs just a little harder. Especially, I think, when you have a situation where water isn't readily accessible on site in the health facility. Sometimes they have to get water from an offsite location.
Perfect. Well, thank you so much for presenting today. We are out of time for questions, but the chat box will remain open. So I encourage our attendees and also our speakers to continue to engage in the chat box. Up next, we have Stephanie Sangalang from the University of Bonn Center for Development Research. Stephanie, if you would like to unmute yourself and queue up your slides.
Yeah, thanks so much, Darcy. Are you all able to see and to hear me?
Yes, you're good.
Okay. So greetings from Bonn, Germany. My name is Stephanie Sangalang, and today I will be sharing the preliminary results from a WASH intervention study. It was a cluster randomized control trial that we conducted in 15 public schools in Metro Manila, Philippines. And to our knowledge, our study was the first of its kind to examine health literacy in this age group, school-aged children and adolescents, and the relationship between health literacy and hand washing, as well as impacts on health outcomes. Inadequate water, sanitation, and hygiene is problematic because of increased mortality and morbidity, in particular from gastrointestinal diseases such as diarrhea, soil-transmitted helminth infections, also known as worms, and malnutrition. The United Nations Sustainable Development Goal number 6 highlights the importance of addressing inadequate WASH in order to provide clean and safe water for all. In the Philippines, inadequate WASH is a serious problem because of the restroom facilities lacking, for example, water and soap, as well as what we found in a previous observational study prior to this trial, a shortage of toilets and urinals and hand washing units. Other reasons why this issue is problematic in the Philippines is because of the overcrowding of students on school campuses, particularly public school campuses where the poorest children attend school. And finally, ineffective hygiene behaviors and poor hand washing. Now, while many WASH interventions have been implemented in other community settings, such as households, not enough is known about which types of WASH interventions based in schools could be the most effective. So our study then aimed to address this knowledge gap. To do so, we used a cluster RCT to measure the effectiveness of a comprehensive school-based WASH intervention in 3 cities of Metro Manila, Philippines. Now, Metro Manila is considered a mega city. It has more than 10 million inhabitants, but it's technically not a single city. Rather, it's comprised of 16 cities. And in 3 of those cities, we conducted our study. The cities of Navotas, of Quezon City, and the city of Manila. We conducted baseline surveys in June of 2017, involving more than 700 students. We then implemented our intervention. And then 8 months later, we did our follow-up, our end-line survey, which was conducted in February and in March 2018. We focused on 4 specific outcomes: children's health literacy, the nutrition status, hand washing, and school restrooms wash adequacy. We measured these outcomes during baseline and endline school surveys. These surveys involved tools such as a questionnaire for children, health examinations, visual inspections of the school restrooms, as well as hand washing observations and interviews with the school principal. Health literacy is a concept that describes how a person is able to understand and to use health information to maintain his or her health. We wanted to incorporate specifically hygiene-related health literacy into our intervention with the aim of better understanding how knowledge can drive behavior change, in particular hand washing. Now, our intervention package was comprised of 4 parts: school wash policy recommendations, health education, hygiene supplies, and then facilities improvements. I'd like to now share the preliminary findings from the trial, beginning with the characteristics of study participants. At baseline, we did survey more than 700 students in grades 5 through 10. Now, the main differences between the control group and intervention group were as follows: parents with low education level, which means to say high school level and below, exposure of children to secondhand smoke in the home, and lack of common household items such as a refrigerator or a computer. Now on to the preliminary findings regarding impacts of the intervention on select outcomes, beginning with health literacy. We used mixed effects logistic regression to analyze the results. After the intervention, health literacy improved in terms of knowing when to wash one's hands and for how long. In the intervention group, knowledge of hand washing duration did improve significantly. We also looked at raw health literacy scores related to 3 different topics. First was knowledge about germs or microorganisms. Second was knowledge specific to hand washing. And third was hygiene overall. Scores did improve after the intervention, and score improvements in the control group and intervention group were statistically significant. After the intervention, prevalence of observed hand washing after using the toilet at school was improved from 11% to 24%. This was statistically significant in primary schools. However, in secondary schools, the prevalence of hand washing decreased. After the intervention, stunting prevalence was only slightly increased. Prevalence of undernutrition decreased in the intervention group. Now, with overnutrition, there were increases in prevalence in both control and intervention groups, and this increase was statistically significant in the intervention group. After the intervention, mean HAZ, or height for age Z-score, decreased significantly in the intervention group. The mean BAZ, or body mass index for age Z-score, improved in the intervention group and the control group, but in the increase was not significant in the intervention group. To conclude, the intervention was found to lead to improvements in health literacy, but there are still areas that need to be addressed. For example, continued and persistent lack of knowledge regarding the hand washing duration and actual behavior change, especially in older children and adolescents. As a next step, we see the need to investigate this link between health literacy and hand washing and identify what are the facilitators and what are the barriers. Our data analysis is ongoing. We also see the need for more research related to the impacts of wash interventions on malnutrition, specifically long-term or longer follow-up periods. Finally, our study, to our knowledge, was the first of its kind, again, to examine health literacy in this specific age group of school-age children and adolescents, looking at this relationship with hand washing and health outcomes. We think our research contributes a very important and very timely set of data and knowledge, especially now because of the ongoing COVID-19 pandemic. So on behalf of the research team and my supervisors, Professor Christian Borgemeister and Professor Thomas Kisteman, I wish to thank you sincerely for your time and for your attention. I will be very glad if you can please share with me your feedback or any questions or comments using the chat function, and otherwise my email address is listed here. I'm very eager to hear from you, and I thank you again for your time. I wish you a very successful conference ahead. Thank you very much. Greetings from Bonn.
Great. Thank you so much, Stephanie. And as per usual, please direct your questions to the chat box, and I will read those out for Stephanie to answer. While we're waiting for those to pop up, Stephanie, I'll kick things off by asking you. You looked at both primary and secondary schools. Can you speak to how the intervention differed across those settings and why you think you might have seen different results?
Yes, unfortunately, I don't have a slide showing those differences, but in terms of what we offered, the different age groups, for sure, the content was tailored to the development needs of a primary school child and compared to, for example, a secondary school child. And in particular, what was really lovely was that because our research team was comprised of college students or recent college graduates, we were able to do fun things in addition to lecture type health education sessions in the classroom. We also had things like a poster making contest and a restroom cleaning contest. And then especially fun for the older kids, we did a songwriting workshop. So then the children or the teenagers were able to kind of use what they learned from the lessons that we provided and then use their creativity to come up with different songs related to environmental health and sanitation and hygiene. So that's one aspect. And I'm not sure, was there a second part of your question?
Well, actually, there was, but we have some more interesting things developing in the chat box, so I'm going to redirect there. We have someone asking about how you considered school curricula in your intervention development.
Oh yes, that was central to the development of our intervention because we're really aiming for something that would be sustainable and also makes sense and is acceptable for the community, the school community. Our starting point was really looking at their curriculum, and with the Philippines Department of Education, or DepEd, they have already in place excellent information with health education sessions in their curriculum. In addition to that, we referenced, for example, materials, open resource materials from the CDC, and I think the WHO as well, And then we use those to kind of tailor our lessons. So to answer the question, it played a big role, the local knowledge and the existing curriculum.
Great, thanks. We have someone asking about the imbalances that you found across socioeconomic and asset variables, and how would you interpret your results regarding these differences?
Yes, thank you. I'm going to see if I have anything. Well, here is some information about the background, the household, the parents, and for sure, when it has to do with WASH and children and in schools, the socioeconomic status plays a big part. And so, as I mentioned, our data analysis is still ongoing, so we're going to need to refine our interpretation of results based on exactly what this audience member mentioned. But already we see that there are differences in terms of the family background, the education level of the parents, and even the household environment. We ask the children questions like, at your home, do you have a restroom? Do you have a toilet? Is there running water? And so we're going to be looking at these differences and then basically adjusting whatever interpretation we may have accordingly. And to note also, I think it's really important because public schools in the Philippines, most parents, when they can afford it, they send their kids to private schools. And so when you're looking at public schools specifically, these are really the poorest communities.
Great, thank you so much. Looks like we are just about out of time for questions, but again, I'm going to encourage people to continue to engage in the chat box and welcome our presenters to continue to engage in the chat box as well. And with that, I would like to introduce our final presenter. We have Fatima Zahura with ICDDRB. Fatima?
Hello, hi, Darcy, thank you. Can you hear me okay?
Yes.
Okay. Hello, this is Fatima Zohra, Assistant Scientist from ICDDRB in Bangladesh. I'm the intervention team lead for the Chobi 7 mobile health program. I'm really grateful to my organization and my donor, Johns Hopkins University, for giving me this opportunity. Welcome to my presentation entitled Effect of a Water Sanitation and Hygiene Program
Fatima?
on hand washing with soap. Yes.
Fatima,
Yeah.
your slides are not sharing properly. The only thing we can see is the file explorer.
Okay, can I share it again?
See, you're sharing your screen, but your slides aren't showing. It's just the window. Can you navigate to PowerPoint?
Yeah, it's PowerPoint.
I think she may need to stop screen sharing and then start again and select a different screen.
Okay. Can you share it? Can you see it?
Yes. Now you're good.
Just put it on. Yeah, there you go.
Okay. Is that okay?
Perfect. Yes, I'll restart your time.
Okay, thank you. Thank you, Darcy. Hello, this is Fatima Zohura, Assistant Scientist from ICDDRB in Bangladesh. I'm really grateful to my organization and my collaborator, Johns Hopkins University, for giving me this opportunity. Welcome to my presentation entitled Effect of a Water Sanitation and Hygiene Program on Hand Washing with Soap among household members of diarrhea patients in health facilities in Bangladesh, a cluster randomized control trial of the Chobi 7 mobile health program. The study I presented today was recently published in the Journal of Tropical Medicine and International Health. I have previous publications on structured observation. I observed hand washing practices in health facilities. Besides this, I have 25 more publications as co-author. Here's the diagram of our study. So our principal investigators are Dr. Christine Mary George, Associate Professor of Johns Hopkins University, Dr. Munirul Alam, Scientist of ICDDRB. I'm really thankful to our donor, USAID, NI8, JHU Center for Global Health. There are 5 study teams who are working together to implement Chobi 7 program. Diarrhea is the second leading cause of child mortality globally. In Bangladesh alone, there are estimated to be over 76 million diarrhea episodes each year. A hospital setting is a high-risk environment for transmission of infectious agents. We set our study rationale based on our previous studies findings. We have found that the household members of diarrhea patients are at a much higher risk of developing diarrhea diseases during the 70 period after the diarrhea patient of the household patient's presence at the health facility for treatment. This risk is 100 times higher for cholera. Actually, this is especially because of taking care of the children of the patient in the household setting, hospital settings. You can see in this picture, a mother who is taking care of her children and sharing the facilities like the foods and not very common to wash hands with soap because of the lack of attendees in the hospital. So, in an effort to reduce diarrheal diseases among household members of diarrhea patients, our research group developed the cholera hospital-based intervention for 7 days, that is Chobi 7. Chobi is a Bengali word which means picture, and 7 for the highest risk of period of getting diseases in the hospital settings. So the Chobi 7 WASH program includes a pictorial module delivered by the health promoters. You can see bedside to the patients. They like to educate the patient and the accompanying household members. It includes the hand washing with soap and safe water storage and safe drinking water with chlorine for high risk, like 7 days. The objective of this study is to evaluate the effectiveness of Chobi 7 program delivery in increasing hand washing with soap in health facility setting among the family attendants of patients. We conducted this study in Dhaka. Dhaka is the capital of Bangladesh. There were 2 tertiary level health facilities. We conducted this study in one government hospital and another one in private hospital. The study period is December 2016 to April 2018. There are 404 diarrhea patients and their accompanying household members who took part in this structured observation in the hospital settings. Within 24 hours of intervention, so we actually start the observation in the hospital settings. So we conducted a randomized control trial of Chobi 7 program based on the date of arrival to health facilities in 3 study arms. The standard message arm, who received message on oral rehydration solution given by the government of Bangladesh. There were 2 intervention arms. Here, the health facility visit plus hand washing station arm, who received the pictorial module delivered by the health promoters, a plastic made hand washing station, a bucket with lid and at a tap and stool and basin, and a soap water bottle made by detergent powder and water. The other intervention arm, who received the same intervention except the hand washing station, they just received the soap water bottle. Within 24 hours of intervention delivery, we conducted 3-hour structured observation at the following key times: feces and vomit related events, like after using the toilet, after cleaning child's anus, after removing a child's feces, after cleaning a patient's vomit or feces. Food related events, before cutting fruit or salad or mashing foods, before eating, before feeding a child or patient. Now I will go to my results section. I will start with hand washing with soap at food, stool, and vomit related events combined by structured observation. We observed 58% hand washing with soap in the health facility visit plus hand washing station arm, 51% hand washing in the health facility visit plus soap water arm, compared to 25% in the standard message arm. For the odds ratio, compared to the standard message arm, we found 4 times higher odds of hand washing with soap in the health facility visit plus hand washing station arm, and a 3 times higher odds of hand washing with soap in the health facility visit plus soapy water arm. Both results were statistically significant. Now I like to move on very specific events. So we found at stool and vomit related events, 57% hand washing with soap in the health facility visit plus hand washing station arm, 49% in the health facility visit plus soapy water arm, compared to 29% in the standard message arm. For the odds ratio, we found 3 times higher odds of hand washing with soap in the health facility visit plus hand washing station arm, 2 times higher in the health facility visit plus soapy water arm compared to the standard message arm. Here, the only result of health facility visit plus hand washing station arm was significant. Now I like to discuss about the food related events. Here we found 25% hand washing with soap in the health facility visit plus hand washing station arm, 19% in the health facility visit plus soapy water arm, compared to 9% in the standard message arm. For the odds ratio, compared to the standard message arm, we found 3 times higher odds of hand washing with soap in the health facility visit plus hand washing station arm, and 2 times higher odds of hand washing with soap in the health facility visit plus soapy water arm. Here we also found that the result of health facility visit plus hand washing station arm was significant. Now in the conclusion part, I like to say our program increased hand washing with soap among household members of diarrhea patients in a healthcare facility setting. Our findings suggest that the Chobi7 presents a promising approach to facilitate hand washing with soap behaviors in health facilities. We are currently partnering with the Bangladesh Ministry of Health and Family Welfare to develop a scaling plan to deliver the Chobi7 program across Bangladesh, especially who received the health facility visit plus soapy water arm, because it's a very minimal cost intervention. So now I'd like to thank to our study participants, our hospital staffs, and our court owners. So now I'd like to open the floor for questions. Please, if you have any questions, then you can ask me or you can email me. Thank you, Darcy.
Great, thank you, Fatima. So for questions, again, we're looking at those in the chat box of Pathable. So if you would like to enter those there, I will relay them to our speaker. Fatima, while people are getting started with that, I'd like to kick off by asking, could you speak a little bit about your work with the scaling plan and what that looks like?
Okay. So actually we are partnering with the government of Ministry Health of Family Welfare. So they are suggesting us to scaling this program, especially this arm. You can receive that a pictorial module delivered by the health promoters in the health facility settings, and a soapy water bottle made by plastic bottle and the detergent powder, which cost like $0.07. It includes recycled plastic bottle and detergent powder. So it's a very minimum cost. So we have like more than 5,000 community clinics in the government facilities. So we are like to partnering with the government to train up the all staffs of the health facilities so that they can train up, they can build a corner of the diarrhea where they can train by showing the pictorial module and how to make the soap water bottle. And hand washing station is very common, you know, it's a very locally available plastic bucket and stool and bowl, and tap is also common, so they can easily prepare. And water is not a problem in Bangladesh. So we don't have any water crisis. So the soap thing, actually, people think from our formative research, we found that soap is a very costly thing and they feel disgust to share with others. So Dhaka slum areas, people like to share the toilets and kitchen areas with other 4 to 5 family members and the other families. So that's why I like to plan to scale up this Chobi 7 program, who is delivering only hospitals counseling and the soap water bottle.
Great, thank you. I'm scrolling through the chat box to look for more questions. The chat box is quite active, which is great, but it means that sometimes things can get lost. So if you had a question for Fatima in there earlier and I'm not seeing it, please do retype it so that we can be sure to get those to the speaker. I'm not seeing any come up, Fatima, right now.
Okay.
But I'll ask one more to kind of keep us going, and maybe we'll get another one in the box. What do you think are next steps for this research?
I mean, I already have mentioned that we are planning to scale up. So we are planning to train the government health facilities staffs on this Chobi 7 program. So actually, this study has nested in our larger study, Chobi 7 mobile health program. So we are sending mobile messages. You can find in our publications, Chobi 7 mobile health program, where we mentioned that how mobile messages help and disseminate the wash-related behaviors to improve hygiene issues in Bangladesh. And we try to train people how to make soap water bottle, so that multiple soap water bottle for using key at toilets or kitchen areas or inside in the room. So that's our plan.
Great, thank you so much. It looks like that's about it for questions in the chat box. If people have them later and would like to answer them, again, I'm encouraging all of our speakers and presenters to continue to engage with the chat box after we end this session. But I'm going to close us out for now and encourage you all. There are poster sessions today beginning at 3:15 today. So please do attend the poster sessions and enjoy the rest of the conference. Thank you to all of our speakers.
Thank you so much. Thank you for
Thank you.
listening us.